Good afternoon, everybody. My name's Ragada El-Damanawi. I'm one of the consultant nephrologists at the Sheffield Kidney Institute in the UK. I'm very pleased to be invited to present at this conference. I'll be talking to you today about IgA nephropathy and some of the advances that have happened of late. So IgA nephropathy is one of the commonest primary GNs worldwide. We know that it's a leading cause of kidney failure, particularly in our younger population. Overall, it tends to be slowly progressive. A third of patients will reach end-stage kidney disease within 20 years of their presentation. But one of the challenges of managing IgA nephropathy is the fact that it's actually quite a heterogeneous condition, both in terms of the clinical and pathological ways in which it presents. We know that there's significant differences in outcomes and disease progression according to ethnic groups. And as we've understood more about the immunopathology of the condition, there's been an increasing interest in the use of immunotherapies, and that's particularly thinking about steroids. But part of the challenges there is really the conflicting results that have come from clinical trials of steroids in IgA nephropathy. And it actually makes it quite difficult to justify the treatment based on some of the side effects that these therapies have. Now, my aim was to present a case which will really go on in the background and probably stimulate some of the evidence that we look at and how it progresses. So we had a 26-year-old Caucasian male who presented to the emergency department really with very non-specific abdominal pain, investigated, found to be nothing of concern, but was noted to have a blood pressure of 183/110. Now, he was also noted to have a creatinine of 203, which gave him an eGFR of 38 mils per minute. He had no previous results on the system, so it was unclear whether this was acute or chronic. He went on to be referred to nephrology, a very active urine dip with about 3.6 grams of proteinuria per day. Of interest, he'd actually had an abnormal urine dip at his GP surgery since 2015. His ultrasound scan showed that he had two 12-centimeter kidneys, which were unobstructed, and his soluble immunology was pretty much unremarkable. He went on to have a biopsy, which showed that 4 out of 7 of his glomeruli had mesangial and endocapillary proliferation. He had evidence of crescents and sclerosis, and the background kidney didn't look too bad, with 20% fibrosis and atrophy. There was dominant staining of IgA, and electron microscopy was consistent with good-going mesangial deposits and some mild effacement of the foot processes. So the first thing to do, which we all do with our patients who we think have IgA nephropathy, is to MEST score them. So in this case, he probably is an M1. He's got more than 50% of his glomeruli showing mesangial hypercellularity. He has evidence of endocapillary hypercellularity. He's got sclerosis, not too bad in terms of the background kidney, and unfortunately does have crescents. So that's his MEST score on the right. So as a physician, actually, the questions that you have in your mind at that point in time are probably not dissimilar to the questions that your patient has, which is, what is his specific risk of kidney disease, given that it's such a heterogeneous condition? Should I use immunosuppression? What's going to be the risk-benefit balance, particularly in somebody who's incredibly young? And what evidence am I going to present to my patient to enable them to make an informed decision and encourage them to engage in this process? So one of the key things is a standardized and validated risk stratification tool that's disease specific and allows you to predict the prognosis. And that's really important because it gives you some idea of how the disease might progress in that particular patient. And It also allows you to identify people who you think might be at high risk of progression and therefore would warrant immunotherapy. And it's really critical to the way in which we design our clinical trials, because you obviously want to include patients who are at high risk of progression, particularly in your quite invasive trials. You enrich your trial population with progressors. It means that you can deliver more efficient trials. So this, the International Risk Prediction Score for IgA nephropathy is probably one of the largest studies and more recently the most used for IgA as an IgA prediction tool. And it uses more than 4,000 patients with cohorts of IgA nephropathy that have come really from across the world, including Asia, America, and other places. And the cohorts are divided in two. They used a derivation cohort, which is the cohort that they used to develop the prediction model. And then they had a validation cohort. They included patients who were over the age of 18, had biopsy-proven IgN with MEST scores and some follow-up EGFR data. And what they wanted to do was to look at was to develop a model with the clinical and histological parameters that would allow them to very accurately predict the composite endpoint of either end-stage kidney disease as defined there, or a 50% reduction in EGFR. So they developed several models. So they had a limited clinical model, which just included EGFR, proteinuria, mean arterial pressure. They developed another model where they added the MEST score to that, and then a full model which included these factors as well as things like age, race, and the use of immunosuppression and renin-angiotensin inhibition at the time of the biopsy. And they also developed a second full model with and without race, or without race rather. And actually the full model was the most accurate at predicting the primary outcome. A couple of things to mention. So race was self-reported and divided into these categories, so quite limited really. And when they included crescents, it didn't reach the threshold for inclusion. So crescents weren't significant, so they're not actually included in this model. And this is just to show that actually, if you look at the predicted 5-year risk of the primary outcome versus the observed 5-year risk of the outcome, the model with and without race was actually pretty accurate. And most of you will have seen and used the risk prediction tool online, which is now available on the web and also as an app. And you basically fill in your clinical and your histopathological parameters, and it will produce something that looks like this box down here that tells you that the risk of a 50% decline in EGFR or progression to end-stage kidney disease at 5 years for your specific patient is whatever percentage it is based on the parameters that you've input. So regardless of risk of progression, really, the mainstay of management in IgA nephropathy is actually supportive and non-immunotherapy based. And in line with many kind of CKD conditions, the main emphasis is blood pressure management and reducing proteinuria. We know that controlling these factors are really important for cardiovascular risk and subsequent disease of kidney disease progression. First line is either an ACE inhibitor or an angiotensin receptor blocker. There's pretty much no evidence that dual blockade with these agents is superior to single blockade. We target a systolic blood pressure of less than 120 and really try and get the proteinuria down to less than a gram per day. Now, also important is some of the other factors, which is sort of weight management, salt restriction, smoking cessation, reduction of alcohol. And these supportive measures really need to be continued for a minimum of 3 months, 3 to 6 months ideally, particularly if your patient is stable and their kidney function is not deteriorating. So coming back to our patient, so he comes back to clinic months later. He's got reasonably well-controlled blood pressure. His creatinine is a tiny bit better at 189 maybe. But he's still got a good going proteinuria with 3 grams per day. He's on maximal ACE inhibition and now on some bisoprolol. And I've used the prediction tool that I showed you previously. His risk of progression at 5 years is quite significant for a 26-year-old at 34%. So is this the point at which we should be considering immunosuppression? So proteinuria is actually a powerful predictor of kidney outcomes, and so much so that it is used as a surrogate marker for disease response in IgA nephropathy. So reduction in proteinuria is often a good sign for renal outcomes. And here is some evidence, and this was from the Toronto IgA nephropathy registry, looking at survival from renal failure based on how much proteinuria patients have. And you can see that more than 1 gram per day of proteinuria is associated with significant renal outcomes. So you'll also be aware that KDIGO recently updated the clinical management guidelines for glomerular disease. It's actually a very robust and a good guideline to read. So what do KDIGO say? So in patients who remain at high risk of CKD progression, despite maximal supportive care therapy, they would advise a 6-month course of glucocorticoid therapy. Important to have discussions with your patients about the risk benefit, particularly in patients who have an EGFR that's less than 50, because they're more likely to suffer with toxicity. So how do they define patients who are at high risk of CKD progression? So essentially those who have ongoing proteinuria of probably more than 1 gram, despite at least 90 days of optimized supportive care. So here's the algorithm that KDIGO suggests. Patients who've got proteinuria of more than 1 gram per day, despite having the supportive care for 3 months, and that's kind of the strategies that we discussed. Firstly, consider enrolling them in a clinical trial. If their EGFR is above 30 and you think that they're not at risk of significant toxicity from glucocorticoids, then the risk benefit will be in favor of giving a trial of steroids. If the EGFR is less than 30, then steroids would not be appropriate and you just continue with supportive care. So where does the evidence for steroids come from? So this is the landmark STOP IgA nephropathy trial. And so this was an open label randomized controlled trial. And essentially they recruited patients who went into a 6-month run-in period with optimized supportive care. At this stage, the patients had biopsy-proven IgA nephropathy. They were 18, 70 years old, significant proteinuria, and they had to have other risk factors for progression, particularly hypertension or evidence of renal impairment at baseline. So once they completed the run-in phase with the maximal supportive care, it was interesting to note that actually at least 1/3 of them had had a response and didn't then need to be randomized. So their proteinuria had significantly decreased. The rest, so 162 patients in the end, were then randomized either to continue with optimized supportive care or immunotherapy. And they were divided into 2 groups. So if they had an EGFR above 60, they had steroid monotherapy. If they had an EGFR that was between 30 to 59, they got prednisolone and cyclophosphamide for the first couple of months and then went on to pred and azathioprine maintenance. Now, the thing to bear in mind here is that actually in terms of proteinuria post-run-in, not a high level of proteinuria, so 1.6 grams per day, and actually reasonably preserved EGFR in a European population. So in terms of the primary outcomes, they looked at full clinical remission. That was resolution of the proteinuria with an eGFR that didn't change by any more than 5 mils per minute. And the result obviously shows that there was a benefit to actual immunosuppression in addition to supportive care. But most of this was driven by a reduction in proteinuria rather than eGFR effects. And this is confirmed by the second primary outcome, where they look at a decrease in eGFR by more than or equal to 15 mils per minute. And there wasn't really a difference between the groups. Now, again, when you look at the absolute eGFR change in the supportive care group, it was minus 4.7, minus 4.2 in the interventional group, and that wasn't different. So essentially, most of the benefit was observed on proteinuria. So the therapy reduced proteinuria, but that didn't translate into a positive effect. Didn't translate into a positive effect on eGFR. Part of the reason that might be is because this was a group of patients with not much proteinuria and reasonably preserved eGFR, and so the argument is that maybe they were at slow risk of progression anyway, and a trial period of 3 years probably wasn't long enough to observe a beneficial effect on kidney function. In terms of serious adverse events, so the number wasn't different between groups, but there did seem to be an increased number of infections, impaired glucose tolerance and weight gain in the immunosuppression group, which you would sort of expect with steroids. So they also looked at the long-term outcome of patients in IgA nephropathy and followed them up for 7.4 years. Looking for a primary composite outcome of either death, end-stage kidney disease, and 40% eGFR decline. And again, there was no difference between the supportive care group and the interventional group, bearing in mind that this was observational data at this stage. So, not a strongly positive result, essentially, from the STOP IgA trial. So then we move on to the testing trial, which is a double-blind randomized control trial. So the initial plan had been to recruit a sample size of 750 patients who had IgA nephropathy, quite a wide range of GFR and going down as low as 20, deemed at high risk because they've got a urine PCR of more than 1 gram per day. They had a run-in of 3 months of optimized supportive care, and then were randomized either to placebo or high-dose steroids in the form of oral methylprednisolone, and the plan was for a 5-year follow-up. The primary outcome was 40% decline in GFR, end-stage kidney disease, or death due to kidney disease, and they had some pre-specified safety outcomes which would be in line with what you would expect from steroids. And as you'll be aware, the trial was stopped early after they recruited just 262 patients, and that was because the Data Monitoring Committee was concerned about the excess of adverse events in the interventional group, which included a couple of deaths. So in terms of the population, it's interesting to note that this is the differences between the population here and in the STOP IgA group. So predominantly Chinese patients, blood pressure reasonably well controlled, but the urine protein excretion was higher at baseline compared to the other population, and the renal function was also lower. So in terms of the composite endpoint, you can see that there was a clear benefit to the interventional group as compared with the placebo, with a hazard ratio of 0.37. Methylprednisolone was associated with a significant reduction in proteinuria and a much slower eGFR decline. And you can see again that just reiterates the eGFR decline in the placebo group at nearly -7 mils per minute compared to -1.8 in the methylprednisolone group. But then we look at the serious adverse events, and methylprednisolone, in particular, within the first 3 months, was associated with an increased number of serious adverse events. These were predominantly infective and related to respiratory infections and PCP. And so this led to some modifications to the protocol, and then the ongoing testing 2 trial, which was presented recently at the ASN. And just to say that the next slides are taken from Professor Perkovich's presentation at the ASN, so they're not mine. So what was the difference between testing 1 and testing 2? So what did they do differently? So the first thing was that the dose of methylprednisolone that was given was much lower, almost half. All patients got PCP prophylaxis. They increased the lower limit of EGFR from 20 to 30. And rather than trying to recruit 750, they adjusted the sample size to 500. Again, the vast majority of this population was Chinese. Some of them had had some previous immunosuppression. And in terms of the primary outcome, so this was a 40% EGFR decline, renal failure or kidney-related death, and there was a much reduced incidence of the primary outcome in the methylprednisolone group compared to placebo. And sort of a reduction in risk of the primary outcome of about 47%, and that was statistically significant. Then they compared sort of almost testing 1 to testing 2, so the full dose to the reduced dose, and again a significant decline in the reduced primary outcome with methylprednisolone, showing a clear benefit to therapy there with both dosing regimens. And then the serious adverse events. So I showed you in testing 1 the increased kind of risk of serious adverse events that was associated with the full dose regimen. There was no difference in the low dose regimen between the placebo group and methylprednisolone, indicating that it was reasonably safe. So reduced dose steroids were helpful in reducing proteinuria and kidney disease progression in people with IgA nephropathy. There was no increased risk of serious adverse events with the reduced dosing, and it seems to be reasonably safe and well tolerated. So back to our case. So in terms of his protein excretion, so he started steroids here where this red arrow was, and you can see that it's gone from about 4 grams per day to less than half a gram per day, which was an excellent response. His kidney function, so his EGFR is stabilized at around the 40 mark. So that's it in terms of the big kind of corticosteroid trials so far, but I wanted to present the Nephropathy trial very briefly. So this was a phase 2 trial that used targeted release budesonide, which gets released directly into the distal ileum, so avoids first pass metabolism. So there should be less than 10% that gets absorbed into or systemically, and therefore should be associated with less side effects. And 150 patients were randomized to either low dose budesonide, double the dose of budesonide, or placebo. These were all patients that had IgA with significant proteinuria and an EGFR above 45 mils per minute. As usual with these trials, they had a run-in with optimized supportive care, followed by the treatment period. And the primary outcome was the change in urine PCR from baseline to 9 months. And this is actually a very encouraging result. So this is the mean change in PCR from baseline, and you can see that there's a significant reduction with both dosings of the budesonide. And there's also, so this looks at the mean change in EGFR from baseline, and again, there seems to be a stabilization of eGFR compared to the placebo group, which had a significant decline. And the interesting thing about this is that actually, although one of the primary reasons for using the budesonide would be less systemic absorption and side effects, you still do get what looks like steroid-related side effects, so it doesn't completely obliterate that. There's an ongoing NephGuard trial, and there seemed to be an abstract in KI Reports, which was reporting some early results if anybody is interested in looking at that. That's the sort of follow-on phase 3 double-blind randomized controlled trial of budesonide. So in terms of conclusions, supportive measures really do remain the mainstay of management in IgA nephropathy. If you have somebody that's at high risk of progression, there is a role for immunosuppression, but that requires a significant amount of kind of shared decision making and really making sure that patients are aware of the risk-benefit balance. The IgA risk prediction tool is a fantastic tool, but it's to be used at the time of the biopsy. You can't use it to predict a treatment response or which treatment to use. And I don't have time to go into some of the other therapies today, but just to say that there are some therapies, and in particular, there's interest in SGLT2 inhibitors, particularly in light of looking at the post hoc analysis of studies like DAPA-CKD. But a randomized controlled trial of SGLT2 inhibitors in IgA nephropathy would be something that would be quite interesting, actually. And that's the end of my talk. Thank you for listening.